Hey everybody, I have been working at Sanford Medical Center for my practicum, and my research was about Clostridium difficile case control study. To give you a little bit background about C. difficile, it is C. difficile has become one of the most common healthcare related infections worldwide, and it is also the most common infectious cause of acute diarrheal illness in long-term care facilities like nursing homes. Microbiologically, Clostridium difficile is gram-positive, anaerobic, and spore-forming bacteria which survives a long period of time in the environment, and which makes it harder to disinfect it easily. And transmission primarily is fecal oral route, and indirect transmission also occurs in healthcare facilities, which where exposure to antibiotics and environmental contamination occurs. And the spectrum of disease varies from being asymptomatic to have mild diarrhea to life-threatening colitis and also sepsis. So this is impact of Clostridium difficile infection, and CDC categorized type of C. diff infections into three broad categories based on the onset of symptoms. As you can see, the first one is hospital onset or hospital acquired. When we say hospital onset, the onset of symptom occurs greater than 2 calendar days or 48 hours after the date of admission, and this hospital onset C. diff has annual incidence of about 165,000, and it is also responsible for about $1.3 billion costs and 9,000 annual deaths per year. And the second one is community onset hospital acquired, and if the symptom onset occurs less than 4 weeks after discharge from a healthcare facility, then they are categorized as a community onset. And as you can see, this category has lesser annual incidence as well as a lower cost when it is compared with the other two. And the third one is one of a huge problem currently worldwide, especially in developed world, and it occurs while patients are staying at nursing homes, and it has the highest annual incidence rate of 263,000, and it is responsible for about 2.2 billion costs, and it has a mortality of 16,500 per year. Risk factors for C. diff infection include exposure to antimicrobials, recurrent hospitalization, advanced age greater than 65 years, underlying illness like diabetes mellitus, heart conditions, cancer, and so on. And other risk factor is also immunosuppression secondary to maybe drugs, AIDS, or chemotherapy. And some research also stated that tube feeds and gastrointestinal surgery has some potential risk factors for C. diff infections. Other than that, use of proton pump inhibitors or H2 blocker drugs can cause or can be one of the risk factors for C. diff infections because um, they are gastric acid separation medications. Recently, hospital-acquired C. diff has increased in incidence at Sanford Medical Center in Fargo. So the hospital infection control team took the initiatives to evaluate the sustained C. diff outbreak in their local hospital. So that's why this study is carried out in order to identify any modifiable risk factor to interrupt the high rate of C. diff infection in Sanford. And the objectives of our study include: the first one was to confirm that this nosocomial outbreak of C. diff actually meet the true definition of C. difficile diarrhea through documenting the presence of 3 or more liquid stools in a 24 hours period. And the second one was to rule out other factors that could account for the diarrhea, such as use of laxatives, because laxatives has a side effect of diarrhea. And the third one is to assess the potential risk factors for C. diff infections, like I have been mentioning prior this slide. And the fourth one is to assess the novel real-time locator system technology, which is recently implemented in Sanford, to see if exposure to similar piece of equipment could be a risk for C. diff infection, higher incidence. And the methodology we used is the study design is a case control study. As we all recall from our previous AP class, the initial step is having a case definition for the disease or problem. So we defined our case as patients who acquired C. diff during their hospitalization greater than 48 hours after admission. So our cases were identified by the Hospital Infection Prevention Service as patients who meet the case definition. And control patients were randomly selected and matched to our case patients in a 2-to-1 ratio, meaning we had about 83 cases and 166 controls for our study. All study subjects were selected from hospitalized patients admitted from August 2014 until May 2015. And our controls were randomly selected using a software called Random Generator Number from hospitalized adult patients who were admitted during the same time interval as the kids. As you may all know, controls should be as far as comparable as our cases. So children under the age of 18 years, pregnant women, and psychiatric patients were excluded from the control subjects to keep the comparability of the study. And additionally, control patients who developed C. diff infection during their hospitalizations were also excluded from the control pool. Data collection was a huge part of our study, and data on cases and controls were retrieved through review of patient electronic medical records, which is commonly known as one chart or EPIC. Information regarding subject demographic characteristics like age, race, and sex, hospital stay, length of stay in ICU, diet during hospitalization, prior hospitalization, recent abdominal surgical procedure, history of long-term facility residence were all gathered from the patient medical record. And additionally, data on medications taken 30 days prior to date of diagnosis for cases, and 30 days prior to the date of admission for our controls were extracted from pharmacy report. And information regarding associated comorbid diseases for our subjects were collected from patients' medical records, meaning we searched for past medical records for every patient, and it was calculated using Charlson Comorbidity Index scoring system, and this score takes into account the presence of 19 diseases which are weighted on the basis of their association with mortality, and it is calculated according to the number of morbidities affecting the patient. So for each morbidity, a number of points were allocated, and the sum of these points gives an overall Charlson score. So you can also Google this Charlson Comorbidity Index and learn more about this scoring system. A lot of researchers use this method to identify the comorbidities. We also used a new technology that Sanford implemented, which is called real-time locator system. This technology is a wireless tracking device that can track the location of people or equipment within a specific unit inside the hospital. So whatever equipment is tagged to this device, it gives you a full report of that equipment activity. So this technology enabled us to determine any equipment that came into contact with previous C. diff cases, and it also helped us to see if there were any commonalities to location and or equipment in cases more than our controls. So this was all about the data collection, and this is a snapshot of our case report form. So I'm afraid that is visible, but this case report form had about 70 questions that almost address all the potential risk factors for nosocomial C. diff infections. As you can see, if a patient had any immunosuppression, cancer, or prior history of liver disease, and so on. So this software is a secured clinical research software which is called Velos. So I have been entering all the data that I gathered from the electronic medical record to this software, and once the data entry is finalized, it makes it much easier to run the analysis electronically from this software. It's the same as like SPSS or Excel softwares that usually used in clinical research. This is also a snapshot of RTLS report. It is really difficult to see, but this RTLS report shows the time an equipment gets into a room and then exited the room, the duration of the time starting from 0.00 second. It is really quite fascinating technology, and I learned a lot of new things during this practicum experience. So data concerning shared equipment and patient rooms were collected from this RTLS database system, which keeps record of any equipment that came into contact with the previous C. diff case. So the challenge we had during our research was the inability to complete the milestones in the expected time frame, because we have been slightly lagging in our schedule, and data collection and analysis was supposed to be finished at the end of the first week of August, the major states that affected us during the data collection period was difficulty to get access on some restricted database like RTLS. And the other thing is the data was so overwhelming, and it was in-depth gathering of information, which is a little bit time consuming. So currently data collection is complete, and data analysis will begin at near future. I don't have the result of this study yet, but I'm quite confident that this research will have a significant outcome and will probably enable my host organization to design appropriate intervention to control nosocomial C. diff outbreak infections in Sanford. Regarding ethical issues, this study is approved by IRB, and our data was coded and de-identified in order to protect the privacy and confidentiality of our subjects. This is all about my practicum experience, and let me know if you have any comments or questions. Enjoy the rest of your summer.